next abstract that was presented by our group at ASH was a study of pembrolizumab and pralatrexate for relapsed or refractory peripheral T-cell lymphomas. So as we all know, T-cell lymphoma patients have limited treatment options and poor prognosis, and they do represent a great unmet medical need. There is some preclinical data that suggests that antifolates may induce immunogenic cell death and modulate the tumor microenvironment, and that enhances antigen presentation and reduces immunosuppression, while immune checkpoint inhibitors may restore T-cell function. And so together, synergistically, they would be promoting robust anti-tumor immunity. And so based on this rationale, we thought that this combination of pembrolizumab and pralatrexate together would be synergistic. And so we did this study. Essentially, patients who were 18 years and older with relapsed refractory mature peripheral T-cell lymphoma or transformed mycosis fungoides who had received at least one prior line of therapy were eligible. And these patients essentially received pralatrexate administered at escalating doses. Dose level 1 was 20 milligrams per meter squared. Dose level 2 was 30 milligrams per meter squared on days 1 and 8 of a 21-day cycle. This was combined with pembrolizumab, 200 milligrams on days 1 of each cycle. The primary objective of this study was to determine the maximum tolerated dose of pralatrexate using a modified rolling 6 design. So overall, we had 13 patients initiated this study. Patients had anaplastic large cell lymphoma, transformed mycosis fungoides, angioimmunoblastic T-cell lymphoma, extranodal NK T-cell lymphoma, and cutaneous T-cell lymphoma as well. And essentially what we saw was that there were 5 patients who were treated at dose level 1. 2 of them were not evaluable for DLT due to clinical progression during that DLT assessment window. Among the other 3, there were no other DLTs observed, and then 6 patients were subsequently treated at dose level 2. Out of the 6, 1 was inevaluable due to progression after 1 cycle, and then among the other 5, 2 experienced DLTs. 1 was grade 3 fatigue lasting more than 2 weeks, and another one was grade 3 hypertension that resolved to grade 1 after 7 days or more. And so based on the patients that were treated on with this regimen, whether it was dose level 1 or 2, patients either had clinical progression before the DLT window was over, or they experienced DLTs. And so because of those results in the initial 13 patients, the study was prematurely discontinued due to what we were seeing. And so to conclude, the combination of pralatrexate and pembrolizumab was not well tolerated in this patient population. We saw an unacceptable rate of DLTs across those levels. And furthermore, the overall response rate that we observed for the patients who were able to, who did not experience a DLT, it was lower than historical benchmarks for pralatrexate monotherapy. And so based on this, future development of this regimen with the current dose and schedule is not warranted.